MRs fall under Gabby. And so Gabby has been instrumental in not only reading them over at DC, but getting our program up and running, getting the images transferred over to DC, and now working with our techs here to improve the quality so we make amazing images. So we're on the cusp of really pushing forward advanced imaging. So Gabby is a nice Jewish boy from who studied in Texas. That's a story in itself. And then did his training at Yale New Haven, and has been at the hospital center, I think, since 2006, right? 2005, right, when I got there. 2005. So he is now the director for cardiac MRI, and he is also the director for the fellowship program. And he spent the better part of the morning hanging out with you guys, giving you some ins and outs. So I'm really happy. I think you're going to be really impressed with what we can see and what Gabby can show us and what MRI can do. And the hope is that we move into that realm really aggressively. All right, Gabby, thank you for coming so much, man.
Thanks, George.
It's good to see you.
Appreciate it. Now, I remember I came to Hospital Center in 2005 to do a one-year fellowship in MRI and CT, and George was junior faculty there, and I looked up to him as me being a fellow and him being a faculty. This guy's got it made. He's already up there in the stratosphere.
Yeah.
So I'll talk a little bit about, it says cardiac MRI, I'll talk a little bit about cardiac CT, but mostly I'm going to talk about cardiac MRI, and this is mostly meant sort of as a little bit of a show and tell, some grand rounds or a lot of data and the like. I'll show a little bit, but that's not really the point of it. I'm going to stand besides this thing. You guys are really nice. There's a box here for short people like me to make me feel really tall, but if you don't mind, I'll just stay down here on the ground. As George said, Union has been doing cardiac MRI and cardiac CT for quite some time. This is nothing new to you guys in many ways, so I don't have a great way to judge what you know and what you need to know at this point in time. As George said, University of Maryland read it for many years and a little bit of distance, and now we took over in July 1. And we're trying to regionalize cardiac imaging, try to bring expertise from across the system to one place. If you're sort of thinking about numbers, my general feel of the numbers has been that Union has done about 100 cardiac MRIs a year and about 300 cardiac CTs. If you want to compare that to what we do in Hospital Center, we do about 900 to 1,000 cardiac MRIs a year, and we do about 1,600, 1,700 cardiac CTs in a year. So I think there's a lot of potential of how to use this technology. Don't really have any disclosures. I do have to mention every time I give one of these talks that gadolinium-based agents in MRI are not FDA approved for cardiac. They go to the same places that they go when you give it for the liver or for the brain or anything else, but there you have it. All right, so what am I going to talk about a little bit today? So we'll start by talking a little bit about cardiac CT. I'll mention a little bit about what we're doing here and where we hope to go and where we're not quite at yet here. I'll talk about a few issues in MRI that may or may not sort of hit your radar screen and our concerns for physicians and our concerns for our patients. And then I'll talk about some specific examples of where we use them, some of it based on what I've seen from here. And this is sort of a short list of some of the things that we'll talk about. So a few words on cardiac CT first. When I started doing cardiac CT around 2005, and we were really coronary imagers. That's what we were. We were sort of a non-invasive cath lab. But just like the cath lab, we've changed. Now the vast majority of what we do is structural heart disease. We do a lot less, as a percentage of what we do anyway, we do a lot less coronaries. What we're doing right now here at Union Memorial is by far and away structural heart disease, and I'll talk a little bit about how we play a role into that. So the biggest thing that we do now is planning for TAVR, and again, I know that with Dr. John Wong here, you guys are very familiar with this, but because this is all non-invasive, imaging and planning becomes the critical element to this. And imaging has evolved, but at this point in time, cardiac CT is really the key imaging tool for TAVR. You prove that they have aortic stenosis with echocardiography, but everything after that becomes really cardiac CT. And there's a few elements to that. The first element is just measuring the annulus. We have multiple sizes of valves. You have to decide which one it is, and we do measures, right? So that's reasonably boring, but important in helping people pick valve size. What's more important in many ways, though, is helping predict complications. And the things that we worry about the most would be annular rupture and paravalvular leak. And understanding the anatomy of the annulus helps us understand that. So this annulus here, which has no calcium around it and is clean and nicely elliptical, would be a low-risk annulus. This is one where the interventionalist really doesn't have any worries, while if they're heavily calcified, for example, you worry about rupture and the interventionalist has to change their plan a little bit based on that. And you also worry about paravalvular leak and the possibility of adverse outcomes related to that. The other thing that's important is the coronary height. So when you put in the TAVR valve, this is the leaflet. You can take the leaflet and just stick it right up against the coronary and obstruct the coronary. You can see the relationship here. So again, understanding this relationship becomes important. In the ideal world, at least the way we do it at the hospital center now, this really becomes a multimodality TAVR planning meeting. So every Thursday morning at 7 o'clock, which I missed this morning to be here with you guys, we have a multidisciplinary team meeting. The interventionalists, the cardiac surgeons, the cardiac imagers, we sit down and we go over every case. We look at the images and then we make a plan. That we're going to use this valve, or we're not going to do the procedure. We're going to protect the coronaries, or we're not going to protect the coronaries. All of these things become part of it. And for us imagers who, sort of genteel, we sit down with our cup of coffee and read studies, it's sort of a fun environment to be in with surgeons and with interventionalists and sort of think about what we're going to do for these patients. We also talk a lot about access vessels. We take pictures of those and help them decide whether they can gain access and the like. So this is a lot of what we do, both at Hospital Center and from the studies we've been doing from Union Memorial as well. A very interesting thing that has come up recently has been looking at what happens to these valves after they're placed. So many of you may have seen this publication. This is from the New England Journal last year, and it's a multi-center publication with 3 people from MedStar. Neil Wiseman, Gus Pichard, and Federico Ash were all authors on this. And it was looking at what happens to these valves afterwards. And this has become a real concern. The way this started was one of the companies, it was the company that put out the Portico valve, got a report from one of the centers that a patient had a stroke, and when they did a TE, they found that there was a thrombus on one of the leaflets. The company took this very seriously and told the FDA about it immediately, and then there was a second case of a thrombus on a leaflet, but no event in the patient. And at that point in time, the trial was halted temporarily. It's been resumed since, while they thought about this. There have been multiple studies, this is sort of the big one, but there have been other ones looking at what's the incidence of this. So what you can see here is, this is the annulus, as I showed you before, in short axis. These are the struts of the valve, and what you can see here is this filling defect, and you can see it here in 3D as well, and you can see how it stops this leaflet from opening, right? These 2 leaflets are wide open, but this leaflet is still in the way. And when they looked at it, they found that a reasonable percentage of patients had this thrombosis. And they had no clinical sequela from it, at least at the time of the trial. There was no strokes, or not an undue amount of strokes, more than you'd expect. And there was no valve malfunction in the sense that when you did an echo and you looked at gradients, the gradients were normal. There was no evidence that the valve itself was malfunctioning. The patients didn't know about it. And this raises a question now. What are we supposed to do about this? Are we supposed to anticoagulate our patients? The vast majority of patients that get TAVR at our institution get dual antiplatelet therapy. This is, again, not something that's known because of anybody doing randomized controlled trials. This is just something that was, part of the standard of care from the beginning. Should they get anticoagulation? That raises the stakes, bleeding-wise and the like. Should you just ignore it? Will it just go away? And the answers are simply not known. What I can tell you is that the FDA has become very interested in, and now in all of the trials, both of TAVR valves as well as in many of the surgical valves, the FDA is mandating imaging afterwards. And by imaging, I mean really CT in the vast majority of cases. You can't see this on transthoracic echocardiography. You could not see this on MRI. There'd be too much artifact. Or TE is the other option, but TE being an invasive procedure, a rather expensive procedure. The vast majority of these trials are now being done with cardiac CT, looking at this. And this is sort of a field in motion right now. We don't know exactly how often it happens, and we don't quite know what to do about it in most cases. But it's a place where CT, I think, plays quite the role. The other big place where we use cardiac CT a lot in structural, again, we've read many studies like this for Union, has been in AFib ablation. As you know, there are multiple treatments for atrial fibrillation, but one of the things that's been growing more of greater interest is doing ablations, right, where we take catheters and we put them around the pulmonary veins and we burn to try to isolate those veins in one way or another. Those patients now, the vast majority of them get cardiac CTs beforehand. The reason that the interventionalists do this is purely really to get this map. They take this map, they put it into their system, and then they're able to merge that together with their fluoroscopy data and guide their catheters and try to burn around this. And what they are looking for is for us to show them if there are any anomalous pulmonary veins and the like. There's two things that may or may not be interesting with this. So the vast majority of them, again, it's just a map. The patients have, normal anatomy, but every once in a while you can see complications. So here's an example of a patient who had a pulmonary vein ablation, and you can see the pulmonary vein stenosis start to creep in here, and which was ultimately treated with a stent. So that's one thing that you see. One interesting thing to look at is, can you forego a TE in these patients? So these patients have AFib often, right? They are at risk for clot formation. So some of these patients require some sort of imaging to prove that there's no thrombus in the left atrial appendage before you ablate the pulmonary veins. And there's good data that CT can answer this question. So traditionally we've done a TE for these patients. There's now multiple studies that show that a CT that shows complete opacification of the left atrial appendage obviates the need for a TE, and you can just do the CT and go. And in our institution, that's what happens. The vast majority of patients that need AFib ablation get a CT either the day before or the morning of the procedure, and then they just go on to the EP lab, and if there's no clot in the left atrial appendage, that absolves the echo lab from supporting the TE in some of these cases. And there's data from UVA as well as some data that we've presented and are in the process of publishing that shows that this is a safe technique, that if you don't see clot in the left atrial appendage on the CT, those patients do well with the ablation. They don't have any embolic phenomenon that happen afterwards. I'll go back and I'll talk a little bit about coronaries for a moment. So like I said, this is what was our bread and butter originally, and we still do a fair amount of this, and this is just a CT that shows, again, a tight stenosis down in the left anterior descending artery. The right coronary looks normal, and that's what we did. This one is a little bit more challenging than some of the other techniques that I've mentioned. The main issue with this is coronaries are small and coronaries move. The other things that I showed you are big and they don't move quite as much. Pulmonary veins are big, they're easy to see. The annulus, is a big structure, but coronaries are not. So this one is a little bit challenging. It requires a modern scanner, and here at Union Memorial you guys have a 128 slice scanner, which is a very good scanner. And it requires a lot of patient preparation. These patients need to be beta blocked. These patients need to have nitrates in order to vasodilate the vessels. And if the preparation isn't done correctly, then we get noise. And if we get noise, we can't tell if there's a stenosis. There's some recent data to look at this technique and to say, is this better, right? We have a lot of ways to evaluate a patient with chest pain. You can do biomarkers, you can do stress testing, you can do echoes, nuclears, all sorts of things. So 2 trials came out in 2015 looking at this question. This is the Scott Hart trial that came out in the Lancet from Scotland, obviously. And this was a trial that compared standard of care versus CT in patients. So you came to the ER, you had intermediate risk chest pain, you either got a CT or you got standard of care, whatever that was. Some patients just troponins and follow up as an outpatient. Some patients a stress test in the ER, perhaps. Again, a bit of a different practice pattern. This is in the United Kingdom, so many of these patients got discharged from the ER for a stress test as an outpatient. They had this system that was reasonably slick to make sure patients got good follow-up. And this is what they showed, was that if you had a cardiac CT, your outcomes were better in the long term than if you had the standard of care. And you can see that at least initially, patients did just fine. There wasn't really a big difference between the two of them, but over time it diverged. Also important, I think, to notice sort of the general risk of the population, right? So we're talking about a 2 to 3% event rate over 1, 2, 3 years, right? So again, this is the population that gets this test. It's not the high-risk population that you're especially worried about. This is what we consider an intermediate to high-risk population. And we see this in our own practice. I mean, one of the questions is, well, why did this difference happen? Is it that the nuclear tests miss something acute? or is it something else? And I think that there's a little bit here. One issue is that perhaps the nuclear test is something acute, perhaps not. But one thing that the nuclear test doesn't tell you is anything about is underlying atherosclerosis, right? So if you have a CT, I can see if you've got multiple 20, 30% lesions throughout. And I can tell the referring physician, this person, while they have no obstructive lesion, does not need a cath, their chest pain is not related to an acute coronary syndrome, but they have extensive underlying atherosclerosis, and you should think about this patient differently. Perhaps you'll give them an aspirin. Perhaps you'll give them intermediate or high-dose statins. You may think about this patient differently, and that can make a difference. A nuclear test just tells you if they have ischemia right now, right? So that same patient with diffuse 30% stenosis has a normal nuclear. And you're going to say, Mr. Jones, Mrs. Jones, you're fine. Go home. And you may not understand the true burden of disease in the patient, and maybe that's what made the difference. I don't know the answer to that. I will tell you that in this study, and I'll show you the PROMISE trial in just a second, the cost of doing CTs beyond some of just the general issues of CT, giving them radiation, giving them contrast, is more caths. So there's no question in every study that's compared nuclear to cath, CT gets you, or nuclear to CT gets you more caths. And the reason for that is we see stuff. And CT, if anything, tends to overcall a little bit compared to the angiogram, so these patients get more caths. This is the PROMISE trial that I told you. So this is an international trial based in the United States predominantly, which looked at, again, anatomic testing versus functional testing. So this was a nuclear versus CT trial, right? Everybody gets a nuclear stress test or everybody gets a CT. And you can see no difference in outcome. You can see here the thing. Now, just one thing to mention is that, again, this is a very low-risk population, and it doesn't come out well in this graph, but it's a lower-risk population than the PROMISE trial. The event rates were lower. So the commentary from people who like CT was, well, you were testing too low-risk a population, right? That nothing was going to happen to them ever, so it doesn't matter what test you do. You could have done nothing. You could have swung a chicken over your head. Nothing would have happened to them, so it didn't really matter. So take that for what you will. I think that it was, again, a well-designed trial. This is a large NIH-sponsored trial, but it showed no difference. So I think we can say for sure that CT is no worse than nuclear, right? If you have a patient with acute chest pain, CT is a perfectly reasonable option. It's no worse than nuclear, and whether you believe it's better than nuclear, I guess depends on how you want to look at the data from these trials. And again, there's something to say about that. So that's what I want to say about CT angiogram. From the point of view of Union Memorial, we're going a little bit slow with this, and George has been really very helpful for us. Again, I think the key here is quality. This one is a little bit of a hard test, and if I keep on telling you, A, I don't know the answer because there's too much motion artifact or blur, or B, I overcall lesions because, you know, a mild lesion when it starts to blur from the motion looks like a severe lesion, I'm not doing you a favor, I'm not doing our patients a favor. So we're working to set up processes. We do some coronaries here, but it's a small percentage of what we do. It is something that we are working on being able to offer more broadly to the patients here in MedStar North. I think it's a useful service, certainly in the right patient. Again, patients that can get contrast, patients that we don't mind giving them the chest radiation, so, you know, the intermediate risk patients, and patients where we can get good heart rate control. I think those are the three things we need to think about. So that's what I want to say about CT, and I'll talk a little bit about MRI in a nutshell. So I want to bring up just one or two issues that, again, may or may not be of concern to some of you and some of your patients, and I'll talk a little bit about devices, I'll talk a little bit about MRI contrast, a little bit about pregnancy. I won't mention too much about claustrophobia. I think you guys understand that very well. So this is an interesting article that came out in Medscape, Cardiologist's Biggest Lie, No MRI for Your Patient. I'm interested that that's the biggest lie that we tell our patients, but we've made it to the big time. So can patients with devices get MRIs? And you guys live in the hub of MRIs with devices, right? You're in Baltimore, where Nazarian and Halpern and the group at Hopkins have done really the groundbreaking research on this question. Can patients with pacemakers get MRIs? I'll just mention one or two things first, and that's, you know, I often get calls about coronary stents and vascular stents, and can these patients get MRI? And the answer is yes, they can get them. The second you implant the stent, you can just wheel them into the MRI if you'd like, and do an MRI. The caveat to everything I tell you about MRI safety, and you'll see this in any documentation, is that you're supposed to know the precise device, right? Not every stent is the same, and not every stent has been tested, and I'm supposed to tell you that that's the caveat. However, there's good publications that even in other stents, there have been no reported issues with MRIs and stents, and that's true for both vascular stents and for coronary stents. I'll tell you that there's one AAA device, an older one, that was initially labeled as MRI unsafe, but the labeling has changed. I won't go too much into that. Generally speaking, your patients with stents are fine. The other thing that I get calls about is valves, and again, the vast majority of them, if not all of them, are considered MRI acceptable, whether it's MRI conditional or MRI safe. They're fine. The forces that the heart puts with every heartbeat on the valve usually far outdo the forces that we put on the heart with the magnet. Caveats to that, potentially, number one is if the valve is unstable, right? So if you have a patient with endocarditis and the valve is flopping in the wind, then probably that patient should not be getting an MRI, just out of an abundance of caution. And there's a story that one of the old Star Edwards valves, one of the, those ball and cage valves that goes up and down, one of them there was a concern about safety with it. There aren't a lot of those patients hanging around, but Georgetown was actually one of the places where these valves were used far into the 80s, beyond other places in the country. So we still see these patients here, I think, more than we do in many other places. What about the TAVR valves that we just talked about, both Edwards and the core valve? So they're both labeled MRI conditional, meaning under certain conditions you can scan them. Those conditions are basically the normal ways we scan patients in normal MRIs. So they're okay, although I find it interesting that if you go to the core valve webpage for patients, they say, can you have an MRI with a core valve? Not doing it under the proper conditions could result in injury or death. I'm not quite sure I know what they're talking about. This is the actual labeling from the FDA. It's okay to do. Okay, what about pacemakers? So pacemakers, I won't go into too much here, and you guys would know better than I what your current protocol is here for both MRI conditional pacers and MRI non-conditional pacemakers. So more recently, there have been a bunch of MRI conditional pacemakers that have come out, meaning the FDA said that under certain conditions you can scan them. Again, those conditions are basically the regular MRI scanning conditions that we use. As long as you stay within the usual parameters, you still need to monitor the patients, which has made it very hard. And it's actually very hard, even in our institution, to get a patient with the MR conditional pacer scanned. It requires a lot of resources. And if you read the reports, this is a common problem nationwide. It is not easy. It requires a lot of resources that are not reimbursed by anybody. MRI non-conditional pacemakers, the older pacemakers and defibrillators, again, assuming that they are all transvenous, all the leads work, no abandoned leads. There's a whole bunch of caveats, but again, if it's just a pacemaker that's traditional, that's working, that's put in the way it is, nothing funny going on, we can scan almost all of those patients. Again, it takes supervision, it takes some expertise, it takes resources, all of those things are difficult. The other part that makes it difficult is that Medicare won't pay you for the MRI, which makes it a huge challenge if you do an MRI on a patient with a non-conditional, non-FDA conditional MRI. And that's made a big challenge for both Georgetown and us in trying to do these patients. Contrasts. So there's two things with contrast that I wanted to talk about for MRI contrast. As you know, we give gadolinium. We don't have to give gadolinium for everything, and I'll show you a little bit about that as we look through it. But the first one is the nephrogenic systemic fibrosis, and this has been around since 2006, 2007, and I think everybody here is probably very familiar with this issue. So it's been a strong association between giving gadolinium-based agents to patients with renal dysfunction and then developing NSF. And these are looking at the latest American College of Radiology guidelines. This is when you should be careful, and I think that here at Union Memorial you guys use pretty much these accepted guidelines. So if the patient is on dialysis, they shouldn't get gadolinium. If they have severe CKD, meaning a GFR less than 30, they should not. GFR of 30 to 40, they put quite a caution on it, right? They say it's unstable and you have to be careful. Anything over 40, again, the ACR says it's okay. And then the last thing is AKI, irrespective of GFR. And this is sort of the hardest one that people sometimes don't realize. The creatinine is acutely rising. The GFR is still above 40. Still, you should not be giving gadolinium to these patients. There are obviously exceptions, and if you ever have a question, you should call your friendly radiologist and ask them about it. I'll say from the cardiac side, the answer is going to be no 99.9% of the time. There's almost always something else you can do, and we don't feel that the risk is worthwhile. For other conditions, I defer to the radiologist and the specific condition of the patient. The other one that came up just last year is this whole question of brain deposits, right? So this was, in some studies, they started finding gadolinium brain deposits, or a deposit of gadolinium in the brain. And it was not in patients with kidney disease per se. It was just, regular patients that had MRI, usually patients that had multiple MRIs. And nobody really knows what to make of this. The FDA and the ACR, American College of Radiology, have both put out statements on this, basically saying they're looking at it. So this has been noticed. There was a safety alert from the FDA in July of 2015 saying they're actively investigating, and to date, no adverse health effects have been uncovered. But we're really in sort of the very early stages of trying to understand it. And the issue is the gadolinium itself is quite toxic. You wouldn't want to have it yourself. But the way we give it to you is it's bound in a molecule. And when it's bound in the molecule, then we see it, and then it gets excreted at some point in time. So that's the way we give it, and that way we think it's safe. But what we know is that, as anything else, it can dissociate. It can dissociate out of this molecule and then reassociate itself. And that was what we think happened with NSF, that there were some gadolinium-based agents where it was easy to dissociate. The gadolinium could easily get out of the molecule, and then the patients with renal dysfunction, it wouldn't get cleared, and it would deposit in the skin and other organs. We don't know why this one is happening, but all of us have moved towards contrast agents where the dissociation is more difficult. The older agents where they easily dissociate are basically not used very much anymore, although there's one or two that still are. So again, something that you'll hear about, something your patients may ask you about. I don't have any good answers for you because nobody really does. People are looking at it, but at this point in time, nobody said that you should avoid it per se. The other question that comes up is pregnancy. Can a pregnant woman get an MRI? There's two questions that come up with that. Is number one is, can she get an MRI? Number two is, can she get contrast agents with the MRI? I think this picture answers whether she can get an MRI. Fetal MRI is a thing. It is done, and it's reasonably safe. There's actually the way that the guidelines used to be, and to some degree are that in the second and third trimester we really don't put any restrictions on it. The woman can have an MRI. In the first trimester there was less data and people didn't really know. Some, again, very limited animal data suggested perhaps a risk, so we used to tell people in the first trimester, if you don't really need it, don't do it. That has sort of gone away. The ACR has been weaker about it, and there was a recent trial that came out just in the last month, actually, from Canada, where they've looked at millions of patients that got MRIs, and they've identified about, I forget what the number was, 2,000, 3,000 women in the first trimester who got an MRI in the first trimester, and there were no adverse effects that they could see in that group, which goes along with what the recommendations are now, that if you need the MRI and you're pregnant, you can get it. Contrast agents, very different. The answer to contrast agents is no, and their study demonstrated this as well, that women that did get contrast agents during the pregnancies, there were adverse fetal effects. We do know it crosses the placenta, we do know it gets into the amniotic fluid, and then it has a hard time getting out of there, potentially. So you should not do an MRI with contrast in pregnant women, but a regular MRI is probably okay, again, considering if you need it. So what are some uses for MRI? And for the rest of the talk, I'll just go over a few examples of things we've done here, as well as at Washington Hospital Center. And there's a lot of uses. And one of the things that I find, and certainly it was true for me when I was a trainee, that MRI is sort of a mystery, black box. Nobody is very comfortable with it, and nobody really quite understands what it does. And my fellows have that same feeling to this day. And I think a big part of this is just to demystify it. It's just a regular test like every other test. If it's and if it can help you, then hopefully you can see where it'll fit in. So a few patients where it may help. Poor echo candidates. MRI doesn't have the issue with the artifact from size, right? If you're trying to echo a large patient, that may be challenging to get good acoustic windows. With MRI, if you can get them in the scanner and they're comfortable in there, you can get pretty pictures always. It's not an issue. So it's very nice for that. Poor nuclear candidates, same question as before. where quantification is important. MRI is the gold standard for trying to give you direct volumes and direct ejection fractions. So if the echo isn't sure of what the ejection fraction is, we can help with that. Avoidance of invasive testing, right? Sometimes there's a question that can be answered by TE or cath. Maybe an MRI can help. And this whole one-stop shop thing, I think, is something that has gone away. When I started this again 10 years ago, that was how MRI was touted, the one-stop shop. And I don't really think of it in that way. The first study for an MRI looking at coronaries directly was done by Warren Manning at Beth Israel in Boston in 1991, published in the New England Journal, 20-some-odd patients. So, back then you could get, I guess, 20-some-odd patient trials into the New England Journal. And there was a lot of, excitement. 1991, it's 25 years later, we're not doing MRI for coronaries 25 years later, right? I don't think that this one-stop shop thing is what its strength is. Its strength is a problem-solving tool. I have a specific question. Does this MRI answer that specific question? There is variation in how this is used worldwide, which you can see. The United Kingdom, for example, for whatever reasons, they decided they don't like nuclear stress testing. They like MRI stress testing. They do a huge amount of cardiac MRIs for stress testing and very, very few nuclears for stress testing. In the United States, the exact opposite. We've decided we like nuclear stress testing. We do a huge volume of those, very, very few of cardiac MRIs, and that includes at the Washington Hospital Center and at most sites in the United States. Some of the advantages, again, we can get these various answers in one test, no anatomic limitations, and there's no ionizing radiation. Disadvantages, long acquisition time. So it is important when we get your MRI that the patient is able to lie flat in the scanner, that the patient is able to hold their breath. There's a lot of patient cooperation that needs to happen with this. So one mistake that I see happen not infrequently is patients send me somebody sick. Somebody comes into the emergency room in active heart failure. You're thinking maybe myocarditis, maybe sarcoid, and you just order the MRI along with the first dose of Lasix. I'm going to get you bad pictures then, and I'm not going to answer your question. The MRI is almost never emergent in these types of situations, right? Get the patient healthier. Get them diuresed, get them better, get them to where they can hold their breath and lie flat, and you will get better pictures and a better answer to help your patient. So think of it as, for the most part, most indications, it's better to do it when the patient is stable. There's no rush. Don't get it, the second the patient hits the door, whether they do it at the end of their hospitalization or as an outpatient, but get them to a better position before you send them in for us. High degree of patient cooperation, as I said, lower spatial resolution than CT or TE, so we often miss small masses. Another thing that I see is cardiac MRI, when people think of it, they think cardiac mass, right, myxoma and the like. We're very good for that, but we're not good for small mobile masses. So if you send us endocarditis patients, we won't see the endocarditis, we won't see the vegetation. If you send us somebody with something flicking off a valve and you're thinking, is this a papillary fibroelastoma, for example, we will not see that. We're good for characterizing the mass. So you see a right atrial mass or a left atrial mass and you're thinking, is this a tumor invading from someplace else, or is this a primary tumor such as a myxoma? That's where we can help you by seeing the whole picture, by characterizing the tissue, not so much at seeing these mobile things, especially the ones that are on valves and the like. Expense, it's a more expensive test than an echo, for example. Echo is and remains the backbone of cardiac imaging, and I don't think MRI changes that. And again, the contraindications, right? If you need to order an echo, you order an echo. You don't think twice about it. You need to order an MRI. Do I not need contrast? Do I now need to think about pregnancy, GFR, pacemakers? The patient has an IVC filter. What do I need to know about that? It's a lot of steps for the physician, and you can see why it becomes a little bit daunting at times. All right, so one use that we see a lot is this use, and we've read several of these types of patients from Union in our handful of months doing this, and this is a patient that's not uncommon, comes to the ER, chest pain, troponin is 3, rush him to the cath lab, normal coronaries, what next? Well, so here's one example. This is a 45-year-old African-American female, T-wave abnormalities, troponin of 12.3, straightforward, send him to the cath lab. Let me see if this works. The left system seems fine. No coronary disease, right? So normal coronaries, what now? What's happening with the patient? LV gram, I'll just point out there's a wall motion abnormality right here. This area here is not contracting, right? So something happened, right? We have a troponin, we have a wall motion abnormality, there's no question about it. So this is what the cath report said, not due to obstructive disease, concern for atypical Takotsubo versus myocarditis, cardiac MRI. So we did the cardiac MRI. So to get function information, we don't need contrast. These are non-contrasted pictures, and you can see the function very well. You can see the wall motion abnormality here whenever the picture moves. So we see what that helps. In this way, we're sort of a fancy echo. Again, this is nice if the echo isn't very good, but if you got a good echo picture, you don't really need these pictures here. What we add is this. We gave contrast in this case. And what we see is this area right here. So this is a short axis of the heart, the anterior wall, the inferior wall, the septum, and the lateral wall. And you can see normal is black. Abnormal is white, where the contrast is taken up. And you can see that this patient has this area of contrast uptake. And in fact, over here, there's a little bit of black in the mid. In here, this is an area of no flow at all, where no contrast is taken up because there is no flow into this portion of the myocardium at all. And this is what an inferolateral infarct looks like. And we can say that with a great degree of certainty. This patient has an acute infarct. You don't see no flow in chronic infarct. So this patient had a circumflex infarct. Despite that, and again, this is a different view of the same thing. Again, you can see this white area here in the inferolateral wall. This is an infarct. And when we looked at the cath, we saw this ditzel, right, that looked like it was cut off. That's the best the interventionist could come up with. This is what explained it. What I can say for sure is maybe that explained it. It's in the right territory. Maybe something bigger embolized and went away. Maybe there was basal. I can't answer that for sure, but what I can tell you is the patient had an acute infarct. So that helps you to some degree, right? It takes off myocarditis off the table. It takes Takotsubo off the table. There was an infarction. Second case, 78-year-old woman, MVA, reports chest pain, and again, troponin goes up, goes for a cath. I won't spend too much time on these images, but again, normal coronaries. LV function is poor, and you can see that there's areas here that aren't contracting at all. Again, they said mild disease, cardiac MRI to try to differentiate. And again, here's your function. You can see how the base contracts well, and the apex doesn't contract at all. For those of you who are familiar with the Japanese octopus trap view, this is exactly what it looks like. You're already very suspicious of Takotsubo cardiomyopathy. And the MRI here, you can see the post-contrast images are pure black. So in Takotsubo cardiomyopathy, they have no contrast uptake whatsoever, and this goes along with that diagnosis perfectly, so you know this is stress-mediated cardiomyopathy after an MVA. I'll show you a third case. This is an 18-year-old with chest pain and a depressed ejection fraction on an echo. Again, goes to the cath. These are just still pictures. Coronaries are completely normal. So an MRI shows again that the ejection fraction is reduced. Interestingly, this little bit of white here is pericardial effusion, so he's got a little bit of a pericardial effusion, not much at all. And what you see here is that he's got this area of white here. So this contrast uptake here and this bit of contrast uptake here. And what you see is he's got normal myocardium underneath it really throughout. So this is what we would call epicardial contrast uptake. This is not what you see in infarctions. Infarctions either have transmural or endocardial contrast uptake. This is very, very typical for myocarditis. So again, without a biopsy, and here's a different view of the same thing. Again, you can see that same portion of the lateral wall. You can see how the endocardium is spared. It's completely black. And the epicardium is very, very white. This goes along with myocarditis. So again, this is sort of a nice way to differentiate between these three etiologies and try to think about what you're going to do. The hardest one becomes the infarction, right? If you see an infarction in normal coronaries, now your question is why? And we go back to the cath and we look, and sometimes we find a flush occluded vessel that the angiographer missed at the time because of how it looked. But often we don't, and then you're sort of left thinking, well, was this an embolic event? Was this vasospasm? Was this plaque rupture that recanalized? And MRI cannot answer that question for you. We can simply tell you that it was definitely an infarction, and the thought process should go in that direction. There's a lot of data to show that this works, that anywhere from 9 to 14% of patients referred for acute coronary syndrome type A presentations have normal coronaries, and perhaps something can help you figure out what it is. And again, just based on MRI, this is sort of the breakdown as to what these diagnoses come out to be, with myocarditis being number one. Viability. Viability is a bit of a challenging field, and this is far beyond the scope of this lecture to talk about what we think about viability. But the bottom line question is you have a patient with depressed ejection fraction, multi-vessel disease, and the question is, will revascularization help my patient? Will it make him live longer? Will it make her have a better ejection fraction? And this is a topic that, again, if you follow the literature, has gone up and down over the years. It went way down with the Stitch trial, which showed no benefit to viability. It's now starting to go back up with people developing an interest in it again as other information comes to the fore. The bottom line is we still do it some, and we're asked to answer this question, particularly in patients where you think revascularization is going to be a high-risk procedure. Somebody with a bad EF, horrible disease, where really bypass surgery is the only option, and bypass surgery is considered high risk in this patient. So this is an example of such a person, a 73-year-old male, multi-vessel disease. Importantly, a cath shows 100% mid-RCA occlusion, which is the new lesion, and 100% LAD occlusion and a tight obtuse marginal. So the question is what to do next. The MRI, again, this is just the function. These images, again, I'll just mention, don't require any contrast, and you can see the ejection fraction is reduced. There's wall motion abnormalities, particularly in the inferior inferolateral segments. And this is the contrast. So the contrast shows this transmural infarction right here, sort of in the inferior to inferolateral territories, and it's a large infarction. It starts at the base of the heart and goes all the way to the apex of the heart. So a large inferior infarction. On the anterior side, I told you the patient had 100% occluded LAD. There's also an infarction. You can see this white right here in the anterior to anteroseptal. But this is very different. This is endocardial. You can see that there's black tissue, normal tissue, right above it. So what do we make of these findings here? This is the classic paper from Ray Kim's group. He was at Northwestern at the time, showing what to do with this. So just focus on the first part here. If you look at dysfunctional segments and you look at the percent wall thickness of scar, so anywhere from 0% wall thickness scar all the way to 100%, transmural infarction. If you have a transmural infarction, you have almost 0% chance of recovering function. If you have no infarction whatsoever, you have an 80% chance of recovering function, and then there's some gradient in between. So the anterior septal in that patient that I showed you had, about a 25% infarction. So that person has about a 60% chance of recovering function in the anterior wall, and very close to 0% chance of recovering function in the inferior wall. So what we can tell the surgeon is that the RCA is not viable, but the LAD is viable. And now you can use that information to make a decision as to whether revascularizing the LAD is worth it. I think most people would say yes if the patient is a viable candidate. But imagine the circumstances reversed. The LAD, there's a large anterior infarction and it's not viable, and the RCA territory is the viable one. Well, most patients would not take that, most doctors would not take that patient to surgery, right? We would not do a bypass surgery just for the RCA if we're not planning to touch the LAD. So this information can help you decide, am I going to go ahead and revascularize or not? There's a few interesting things about this concept, and again, I won't go too deeply into it. Number one is you don't care, nor does your patient care, what their EF is after the surgery. What you really care about is how is my patient going to do long term? Are they going to feel better, have less heart failure hospitalizations, or are they going to live longer? And the data there is very mixed. As I said, that's gone up and down over the years, and people don't quite agree on what the answer is, but in specific populations, I think this test is used. The other thing that's sort of interesting is this. If you have no scar at all, you only have an 80% chance of recovering function. 20% of people don't, even with no scar at all, completely viable. And the question is why that is, and that's been replicated in other studies as well, including in one from our institution that we published recently. And nobody quite knows the answer. Why is that? Our hypothesis is, for whatever it's worth, is that there's often a mixed picture, that these patients have an ischemic and non-ischemic cardiomyopathy mixed in. We have one example that certainly comes to my mind always, is a patient that had a bad cardiomyopathy, had triple vessel disease, we were told. We did the MRI, we saw no scar at all, no scar. We told him it's viable. Patient went to the surgery, and a few days later the surgeon comes to us complaining. The patient is really struggling. They're having a hard time with this patient. You told me everything was viable, but the heart isn't picking up. We looked at the cath with the surgeon. The disease was all sort of moderate. It wasn't the worst disease you've ever seen. Well, no scar whatsoever, a disease that isn't really that critical, probably an underlying non-ischemic cardiomyopathy that wasn't quite appreciated at the time. And maybe that's what explains it. I can't guarantee it. But this is something that's been replicated over and over again, that even completely viable tissue, it's not 100%. A few specific cardiomyopathies that are worth looking at. So hypertrophic cardiomyopathy, right? You see this very thick septum. Beyond the pretty picture, this doesn't add much more than the echo can do. If you have a nice, good echo pictures, you don't need me to do this for you. You already know this information. There is data that if you're having a hard time with echo, and this is no great surprise, the MRI can help you, right? If you're having a tough time with windows, we can see things that the echo can't. Where there is a lot of interest in MRIs, again, giving the gadolinium here, with the contrast, you can see that there's areas of fibroses, these white patches in the septum. You can appreciate how different this is from the infarct patient, where it was a nice either transmural or endocardial. This is sort of patchy stuff in there, and there's nice data that this correlates with ventricular tachycardia. And if you look at the guidelines now, this has made it to a 2B recommendation, which is a weak recommendation. But if they have a lot of scar tissue, you should consider defibrillator in these patients. And maybe they'll push you in one direction or the other, depending on everything else. We know there's a correlation between MRI scar in hypertrophic cardiomyopathy and VT. Having said that, it's very common depending on the genetic abnormality. There have been plenty of papers that have shown depending on your genetic abnormality, even 80% of patients have some amount of fibrosis. So again, it's not something that we fully understand, but we do know that it's seen, and it can be seen rather commonly in these patients. And again, this is just some data showing that, again, the amount of LG determines ventricular arrhythmia burden in these patients. Amyloid is another interesting topic. So in amyloid, when you give the contrast, you see contrast uptake everywhere. You don't see any of the nice black tissue that I've mentioned. Up until now, there's diffuse contrast uptake. This is a very common finding for cardiac amyloid, so another use for it. And this is a patient with cardiac sarcoid, where again you can see there's endocardial regions, which look sort of like an infarct, but they're diffuse. There's there's endocardial here and here and here and here. There's no one vessel territory that explains all of this. And in fact, there's also some contrast uptake in the RV. This is somebody with something patchy and infiltrative all over cardiac sarcoid would be a typical finding. If you told me this patient came to the ER with chest pain and troponin of 20, I would tell you this is more likely myocarditis, right? This is not a diagnosis. This is, in and of itself, this is contrast uptake. And then we have to put that together in the clinical picture of the patient as to what it's most likely to be. I'll mention ARVD quickly. So this is a rhythmogenic right ventricular cardiomyopathy. The guidelines really talk about quantifying the RV, and that is the strength of MRI. Echo has a very hard time quantifying the RV in comparison, and you can see the RV nicely. You can see a wall motion abnormality in the RV here and a wall motion abnormality here. You can see the size of the right ventricle. These things are actually challenging on echo. The echo is excellent for the left ventricle. It's a little bit more challenged on the right ventricular side. And the last one that I'll mention, and I think this is my last slide, is thalassemia. This is sort of an interesting thing, and in England this has made quite the stir. So in patients with thalassemia, they die from iron overload to the heart and the cardiomyopathy. And the problem is that once they develop the cardiomyopathy, you may be too late. What you want to be able to do is see the iron deposition before that. And MRI actually is very good at seeing iron deposition. There's something that we do. There's no picture I can show you because it doesn't look like anything, but we can measure something called the T2 star. And if the T2 star value is very low, less than 10 milliseconds, you can see these are patients that did not develop heart failure, and these are patients that did develop heart failure. And you can see that the patients that did not develop the heart failure had T2 star times sort of all over the place, mostly pretty high ones. The patients that did develop heart failure, all of them had very, very low T2 star times. So in England, this has been used a lot. In Greece, this has been used a lot. In the United States, I've seen it a little bit to measure patients with thalassemia or other risks for iron overload state. Measure T2 star time, and if the T2 star time is low, you know that you may need to do something about it because these patients are at high risk. This is developing heart failure within 1 year of the MRI being done. So with that, I've gone over everything. There's a lot more than MRI can do. I won't go through all of it yet. I'll tell you just one or two limitations that we have currently, but hopefully not much longer. One thing that MRI is very good for is congenital heart disease and shunts. That requires sequences we do not have at Union Memorial currently. We're in the process of getting them. We have a lot of support from all sides, both in medicine and in radiology, so I think that'll happen soon. But that's a great use for MRI. And the vast majority of those patients do not need contrast. It's just a plain non-contrast study, and we can see shunts and the like. And I'll leave our information here, and I'm happy to take any questions.
Thank you so much for a great